So good morning, everybody here in Alabama, and good evening to everybody in Nairobi, Kenya. Today it is my distinct pleasure to introduce Dr. Mansoor Saleh, who's joining us, as I just mentioned, from Nairobi. It's really one of the benefits of COVID that we can do this. So Dr. Saleh received his early education from the Aga Khan school system in East Africa, where he then continued on with his medical training in Germany at Heidelberg and conducted his doctoral research at the Max Planck Institute for Medical Research, also in Heidelberg. He received additional training when he came to the US at the Henry Ford Hospital in Detroit, Michigan. And then we were fortunate enough to have him for some time while he did his clinical and translational research training at the Hematology Center here at UAB in the Comprehensive Cancer Center, where he was tenured professor of medicine and pathology and director of the first in-human early drug development program. His area of research and clinical focus is targeted therapy of cancer. And unfortunately, we lost him last January, but he's off to big and great things, where he went back to Aga Khan in Nairobi in January of 2020 and is now the founding chair of the Department of Hematology and Oncology and the founding director of the AKU National Cancer Center. In addition to a robust funding track record from the NIH, DoD, and others, he had an early patent for some of the first antibody therapies. He has numerous contributions to the literature, including a total of 14 book chapters, well over 100 manuscripts, and nearly twice that in presented abstracts. So please join me in welcoming Dr. Saleh, joining us from Kenya, where it's 4 p.m. or 5 p.m.? 4 p.m. in the afternoon. Where he's going to tell us about establishing an academic oncology program in sub-Saharan Africa, real or just a mirage. And considering he's joining us from there, I'm wagering to bet my money that it is real. So thank you.
So Adam, thank you. Thank you for inviting me. I must admit, nobody from the Cancer Center has invited me to come and give a grand rounds. And I really appreciate you guys in pathology, because George Neto was one of the first ones who really supported this move to come to Africa. And I think for some reason, he genuinely believes that we should have a trajectory of knowledge being moved from the high income countries to low middle income countries, which is what I've done. So thank you. I also see Bruce Alexander somewhere in the background there. Many of you know me when I was a fellow. Some of you do not know me at all. And Shuk and others have known me since I came back to do the phase 1 program. I mistook the timing. I was thinking this was 5 o'clock, so I may not be as prepared as I should be, but let's give it a try. And before I give my presentation, which I hope will be not as much data as I would like to, because this is new. I've been here for 1 year, but at least I can show you the trajectory of what it means to do oncology in sub-Saharan Africa. So when people come to Africa, they always think about animals, etc. So I want you to show you this video. That is a real video. Look at it and then I talk to you about it. And watch and listen carefully. You can see there's a leopard in this restaurant. And the birds are taken away. He walks through the restaurant, looks at the cameraman in the eye, and he just passes by. Goes to the rooms where the guests are. It seems as if he has a room in this particular hotel. But this is Africa. This is the real deal. I'm not sure whether you'd have sprung on somebody who goes to the table, but this is the Africa that I've gotten to experience over the last 1 year. And doesn't happen often, but this is what it is when you come to this part of the world. What I want to do is briefly tell you about myself. I was born in Zanzibar, which is not far away from here in Kenya. It is off the island of East Africa. Went to medical school, as Adam says, in Heidelberg, did my research at the Max Planck Institute, went to Henry Ford. At Henry Ford, I heard El Abulio give a talk about targeted therapy of cancer. And I said, that's what I want to do. I was going to go to University of Michigan, where Al was center director, but he moved to Alabama. I had no clue where Alabama was. But I said I would come to Alabama. And I remember very vividly that Sharon Garrison, who was Al's assistant, came to pick me up at the airport in Birmingham, Alabama, in a red pickup with a gun in the holster. You know, one of those rifles that you have for hunting. So that was my first experience to Alabama, and I stayed there for a very long time. Went to Atlanta to do research on behalf of UAB for about 10 years, and then came back to UAB to run the phase one program. So these are the images that, in a way, East Africa, Heidelberg, Henry Ford, UAB, and now here at AKU in Nairobi. And those of you who may not be looking at the map very often, I was born here in Zanzibar. This is the island. I went to school in Dar es Salaam, went to school then in Nairobi, which is where I am now. And, you know, Nairobi, Kenya is a rough part of the world. You see Somalia, where most of Mogadishu, where most of the hijackings happen. Ethiopia currently in war in Eritrea. South Sudan, clearly an area of turmoil, etc. Boko Haram in Uganda. So I think we're surrounded here by rough weathers, and to do work in oncology is both in a way a pleasure, but also it is quite different than in the developed world. When I was young, the Kilimanjaro was nearly half full of ice caves. Today, you barely see ice on Kilimanjaro thanks to global warming. And this on the right streets in Zanzibar, very narrow alleys where I was born and went to school. This is Heidelberg, where I went to medical school, the famous castle. The bridge underneath here was bombed by the American forces twice, but it's been rebuilt since. This is where I went to medical school. I learned German, and my training in Germany was obviously in German. So I go from Zanzibar to Tanzania, to Kenya, to Germany, to Michigan, Alabama, and I'm closing the circle. Maybe it's the last part of my career where I spend time here to do something meaningful, I hope. And you know, I trained with El Abulio, and this was what we call the dream team: Marty Conry, David Curiel, Teresa, Kabi Kazeli, El himself, and we were really the pivotal people at that time. This was a long time ago, who did translational research in targeted therapy of cancer. We were the first ones to give a mouse monoclonal antibody to humans, look at their kinetics, paper published by Kabi Kazeli. We took the same monoclonal antibody, humanized it, and gave it to patients. It was the first chimeric antibody given to men, and then another HA1A, the first humanized antibody given to men. Elle and I worked together on the first immunoconjugate that was given to patients. This is a drug antibody immunoconjugate. Together with Buxbaum, we did work with C225, anti-EGFR, and radiation therapy to look at sensitization of the two. That laboratory work led to a phase one trial by Paco, who's still there, looking at radiation therapy and C225 in head and neck cancer. It was a very successful phase one program, 80% response rate in a phase one trial. And then led to a phase three trial run by James Bonner, who's still at UAB, a randomized trial of giving RT plus minus C225, which led to the approval of C225 for head and neck cancer. So most of my training early on with Elle was in targeted therapy of cancer, and I got into the work of translational research. Things have changed at the UAB at the moment in the cancer center. Things have moved a little bit, but we really were the founding place for targeted therapy of cancer and the translation of antibody therapy, later on gene therapy, etc. So at UAB, when I came back in 2015, I set up a phase one program, a one-stop shop whereby everything phase one was done by this team. We've got a whole team of nurses, data managers on this side, regulatory, administrative people on this side, and all phase one trials were done here at this unit on JT15 that still exists. In the meantime, phase one has become amalgamated with the clinical research unit. When I came to UAB, back to UAB 2015, we had about 3 phase one trials. When I left, we had 33 phase one trials and a number of publications. And I thought we could take that from Alabama to Nairobi and bring it to AKU. That was my vision, and I'll tell you whether it's possible or not, and I'll describe that for you. So this is Nairobi. It is very cosmopolitan. This is Innocent, who is the navigator with me at AKU. Took this picture just a few hours ago. You've got high rises, cosmopolitan places, and this is AKU. The footprint of AKU is right here. You have the new university center, which will be the medical school coming up here. Here on the left-hand side, we've got a 40-bed field hospital established just a few months ago because we are overrun with COVID. At the moment, if you came to Nairobi and had COVID and required oxygen, we have no oxygen in the entire city. There's no place you can get oxygen. If you want to be admitted, there is no hospital bed. And if you wanted to be on a ventilator, there is none available. So we really are in dire stress in our third wave of COVID. And as you see then here on the field here, we have a field hospital, which is isolated, provided to us by the British, where we house patients who require oxygen, do not require intensive intervention. But this is the middle of the city here in Nairobi. And innocently sitting with me, the three things I realized when I came to Kenya is incredibly friendly people, very warming, number one. Number two, every house you see down here has a guard, a gate, and barbed wire. You go nowhere without having to explain to the guard why you want to go in, and you certainly can't sneak in. And so this is a very guarded place, you can imagine. And the third thing I learned is you don't like to be confronted with the cops because you invariably will be stopped for reasons unknown. We'll have to bribe them. And so those are the three things I learned very quickly here in Kenya. But that is probably very common in the developing world. So at AKU, we have 280 beds. The Hemonc unit just established a small incubator inpatient unit with 6 beds. We have about 140 faculty. 2/3 are academic faculty and 1/3 are private practice, because 60 years ago, the Aga Khan Hospital was the first community hospital that was open to anybody with any color, any creed. It was the first hospital during the British rule that opened its gates to any person who needed medical care. And about 15 years ago, the hospital was taken over and became part of a university, which is what you see today. So we are about 15 years old in terms of the university. We have about 130 residents. We do not have a medical school, which is starting soon, but about 130 residents who have come to us as residents, having finished medical school somewhere, somewhere here in Kenya or somewhere in East Africa. Of the 280 beds, we have 11 ICU beds, about 20 ventilators, and approximately 20 what we call high HDU, high dependency unit, which is like a step down unit of an ICU. When that's full, there's nowhere to go in terms of intensive care. But so it's a very small hospital. You asked me why I came to Kenya. Obviously, I was born not far away from here. But in 2011, the chancellor of the university, which is Sanusi Aga Khan, together with the president at that time, opened up what was called the Heart and Cancer Center. And in his address, he said that there are 2 things most sadly shortchanged in the developing world. One was research, and the other one was education. And his philosophy was the combination of informed practice and creative research would provide the ideal context for superior medical education. So in many ways, what I thought was, if I could come down, I could promote best practice in oncology. I could foster translation research, something that I'd done a long time ago, was taught to me from L all along in the last 30 years I spent at UAB. And then I could develop a training program to really train oncologists and cancer researchers here in the developing world, as opposed to them going to the West and then staying in the West. So the triad of clinical care, we already had a small oncology program, 2 oncologists. We already had a very good radiation therapy unit, 2 radiation therapists. We did not do clinical research. Only Alexandria in Cairo, in Egypt, and South Africa, Johannesburg, and Cape Town are those centers that do clinical research. There are no clinical trials in between Egypt and South Africa. I thought I could really bring something to bear because of my training at UAB. And if we can do that, improve our clinical care, bring in clinical research, then we clearly could train our junior colleagues to become fellows in translational research. So that was a vision, and someday with publication and grants, we'll probably deserve to be called a center of excellence. But for today, we have a very small footprint here in Nairobi, Kenya. So we model after the NCI program, obviously a very small community cancer center compared to the NCI. But we have MOUs with Sloan Kettering, Dana-Farber, UAB obviously, Fred Hutchinson, and UCSF. So a number of cancer centers have helped us in a way, formulate something that would look like an NCI cancer center, but very small incubator state. So when I came, Hemonc was a section of medicine. I wanted it to be a department of its own. So you can see that on the right-hand side, I established a department, and obviously I'm the founding chair. We have a number of clinical programs: hematology, oncology, radiation therapy. We have a very strong palliative care program, and we recruit somebody for supportive care. We have no fellowships program, but I'll tell you about the first fellowship coming up, first time ever in East Africa. And then obviously I would report then to the CEO and to the dean. On the left-hand side, we established an incubator cancer center based upon what I learned at UAB. And we want to really establish a multidisciplinary cancer service line. And that cancer center works with the School of Medicine, the various departments, and also works with the School of Nursing, because we have a very strong School of Nursing here. And then I would report to the provost in my role as a center director. And this is a diagram you could pick up at UAB. This is what UAB looks like. Center director, experimental therapeutics, genomic medicine, genetics, cancer population control, women's center, women's cancer. That's the vision I have. And obviously, I probably won't be alive to get all this thing done. It might outlive me, but at least we start with experimental therapy. And we have a clinical research unit that I'll talk to you about, and we've done clinical trials, and I'll tell you about that. And our next really foray should be population science, because there's much population science done here in East Africa, but it's dedicated to infectious diseases and women and children, because those are the most common causes of death. Maternal mortality during childbirth, early mortality of children in the first year of life, and then infectious diseases. But as you can see now, the NCDs are overtaking infectious diseases, but we have to really make inroads in cancer population and control. And that's why our next associate director would be somebody who does this kind of work. So when I came, I had a 3-year plan. In the first year, I told myself, I will establish a cancer center in a framework very similar to what I learned at a UAB, but at a very small scale. We'd have to have an advisory body who would advise me about what to do. We really wanted to have a clinical research unit, because I think it is very categorically important that we do clinical trials on the African population before we bring Western medicine and drugs, which are very expensive to treat the Kenyan or the African population. The genome of this population may be quite different. The pharmacogenomics and the pharmacokinetics may be different. And I thought a clinical research unit would be paramountly important to be able to take one step. And no question, if you do clinical trials, you garner some funding, and that funding would allow us to grow and sustain ourselves over the long term. Importantly, though, when we talk about medicine, at least in oncology, next-gen sequencing, and Shuko knows more about it than I do, is very important. And I thought that in the first year, in addition to a clinical trial, we also have an establishment of trying to do NGS on all triple-negative breast cancers. When I was at AUAB, and Shuko might corroborate this, it cost about $3,500 to get an NGS from Foundation One. It cost me here $5,500 to get an NGS from Foundation One. We're an LMIC. We are a poor country, yet we seem to have to pay twice as much for the same technology that you guys can get much cheaper, and you can even do it at home. And I wanted to try to find a way to fix that. And I really wanted to have our own inpatient units, because patients need to be taken care of by nurses who are trained in hematology oncology, and the care could be much more superior if they had their own unit. So that was my first year plan. And what have we done? Have we done something? Yeah, we established a framework of the cancer center. I work with Ed Partridge. He's on the external advisory board with me, and put together a framework. So we achieved that in the first year. So I came here in January 2020. It's just about year point 1 month or so. External advisory board, we have 3 former cancer center directors who are on the external advisory board. We have the Deputy Minister of Health in Kenya on the external advisory board, and an alumnus from Yale University was also the external advisory board. Clinical research unit, I give you a snippet of it. We established a clinical research unit. Where I am today is in the CRU, donated by a well-wisher who has cancer, and we use this during the 5 month of lockdown of COVID-1. We renovated this place, established this place, trained our nurses, 4 of whom came to UAB while I was there, and we established this CRU during the COVID close down. I'll tell you about the first clinical trial we've done. We have not achieved next-gen sequencing, but maybe Shoko can help me, but at least we'll get some way to do this for triple-negative breast cancer. And I'll provide you some data of work I did with Upender Mani, who can then tell you about the work we did together. And the HemOnc unit, we did establish HemOnc unit. I'll show you a picture. So one thing that brought me here was this article from the Daily Nation. The Daily Nation said cancer research from the West won't work in Africans. Well, it's not the whole truth, but clearly, if we look at the pharmacogenomics of the society here, or even society in South Asia, they may really metabolize drugs differently. The genome is different, their molecular makeup of the tumors might be different. So really, we need to test the drugs in that particular context. And on the right, you see the clinical research unit, which is nearly identical to what I had at UAB in the phase 1 up on JT15. So here we are, this is the clinical research unit. It has the same footprint as we had at UAB. We call it the drug called hope, same motto that we had at UAB. The difference is we have a fish tank. I could not get the CEO at AKU, at UAB to allow me to get a fish tank because as Bruce Alexander will remember, nearly 2 decades ago, there was an outbreak of Legionnaire's disease at the VA because of stagnant water. And as a result of that, they banned having fish tanks at UAB. But at AKU, we've not had the problem, we have it. And on the right, you see the 6-bed inpatient unit, which is obviously most places here don't have private rooms. We have a few private rooms that West Montreal, and this is the 6-bed unit for the HemOnc department. So in year 2, my plan was a fellowship program, a Center for Women's Cancer. 20%, if you look at data from Nigeria, 20% of cancers in the LMIC have some genetic predisposition, not just BRCA, but others. And I thought that it would be very important to have genetic screening, counseling for hereditary diseases. And then obviously, hopefully we can recruit people to do basic science, now that we have a university center, and then clinical faculty recruitment, because it's very difficult to get clinical faculty come from the West to Africa, but we don't have enough here in terms of African trained oncologists, and maybe our own fellowship program would help. And at the moment, only 30% of cancer patients survive, as opposed to 3 times as much, 2.5 times as much in the developed world. With time and technology, and maybe the same kinds of therapy you use, if you could apply them appropriately here, a patient would survive longer, and I wanted to develop a survivorship program. And in year 3, this was really thinking really aloud and very, very obnoxiously aloud. I wanted to have a stem cell transplant program. We have an MOU with UCSF, and they were going to teach us and train us to establish a BMT program and a CAR T-cell therapy program. This is year 3. It was probably all being messed up because of COVID, but it's still a hope. And then over time, we can expand our cancer core facilities. So what have we done at AKU here at the Cancer Center in Nairobi? I wanted to establish a cancer service line. We do have a little bit of oncology. We have surgeons who are trained in breast surgery, surgeons trained in GI surgery, but they do everything together. We are not as subspecialized. A very strong GYN oncology, GYN program, but not a GYN oncology program. Very strong pathology program in breast cancer and other cancers, but really not integrated into the cancer milieu to provide a service line. And we have very good population science, but all dedicated to infectious diseases and women and child. So I thought we could at least integrate it to think towards the objective of cancer. So, and I probably should share some dirty laundry. When I came here in 2019 to visit, I looked at the data. We saw 230 breast cancer cases here at AKU. 60% of those women had surgery here and left and got their treatment elsewhere. The radiation treatment elsewhere, chemotherapy elsewhere. We were losing money, we couldn't figure it out. This is all internal trade going on between physicians in private practice and faculty, where they send people outside your own institution because of certain linkages. A number of 20% of Kenyans go to India for their medical care, including oncology care. And there is this undercurrent of payback that doctors get when they refer patients to India. It is quite not very good, but that's the reality. And my sense was, if we wanted to keep all our breast cancer patients here at AKU, we'd have to find a way to keep them here. So I established a multidisciplinary breast cancer clinic. Besides having a breast cancer tumor board that we have every week, we discuss all complex breast cancer cases, including new cases. All new breast cancer patients now come to the MBC, very much like we have at UAB. They're seen in one-stop shop by the oncologist, radiation therapist, and the surgeon, and a counselor. The woman gets to hear the entire trajectory of her care, knows what needs to be done, neoadjuvant versus adjuvant, and she can decide to go for surgery first or neoadjuvant therapy or adjuvant therapy, etc. And a third of our women have helped us change the direction of our care because of their own personal desires and needs. So we saw about 60 breast cancer patients in the first 6 months of 2020, about 10 a month. And you'll see that triple negative breast cancer were about 18%. ER positive 70%, PR positive 60%, about 20% HER2 positive, and about 20% HER2 negative and triple negative. In the last 3 months, we've only seen 15 patients. Why? Because of the lockdown, surgeries have gone down, people not coming in for their medical care, and the rates have gone down. Instead of 10 patients per month, we're basically seeing 5 breast surgeries per month. But the numbers have remained 29%, about 20 to 29% TNBC, about 70% ER positive disease, 50% PR positive disease. So we see all these patients. They all have a biopsy. We'd love to sequence all of them, especially the triple negative breast cancer. The important part is these women are now really the platform where we could do clinical research. But there was no clinical trial going on in East Africa because we were either not trained. We had totally an agnostic setting with pharma. Pharma goes to South Africa or Egypt, nothing in between. And we had to make a case for that. And I'll give you our experience. But this is at least breast cancer. So we have MBC, very successful. The most common cancer in men in Kenya is not lung cancer. They don't smoke very much. They don't live long enough to smoke to get lung cancer. It's prostate cancer. And very much like an African-American male in Alabama and elsewhere, and the Asian male in India, they have prostate cancer at an early age. So I thought to be able to address that, we need to be able to have a multidisciplinary prostate cancer clinic. So while prostate cancer are dealt with by the urologist, we wanted to see whether we can have a service line whereby they would meet with the other colleagues and do exactly what we did for the breast cancer. So we now have recruited 2 urologists with specialty in prostate cancer. We identified a diagnostic radiologist, MRI, ultrasound, a pathologist dedicated to prostate cancer, oncologist lead, radiation therapist, and starting next month, all prostate cancer patients will be seen in the NPC. And if I look at my data from 2019, prostate cancer was number 3 here at AKU. Number 1 was breast cancer, number 2, acute leukemia, number 3 was prostate cancer. So clearly an immediate need. But we don't have all the technologies as yet. And I just met with the president of the university today to say that what we need in terms of imaging, biopsy, pathology, etc. But that's in the works. We've all agreed now to really do this, and the 2 urologists have agreed to be on board because it takes a whole village to get this done. And in terms of academic progress, just last week, we submitted our fellowship curriculum to the MCFC, which is the leadership organization here at AKU. If approved, it will be a 3-year fellowship in medical oncology, where 3 months of the tenure will be spent outside, or we'll give them training in oncology, a little bit about internal medicine and hematology, and radiation therapy, pathology, etc. We've done that. When I came here, there was no scientific review committee. The scientific review committee was only to look at the thesis of the residents because before you get your MMed, you have to do a research thesis. And the scientific review committee was basically looking at the resident thesis. As part of the Cancer Center mandate, I said we need to have a Cancer Center scientific review committee where we would review our protocols. They would then go to the IRB, very much like we do at UAB, which I had there for many years during ELS time. So I'll tell you about it. We have, as of last week, approved by the institutional board to have a Cancer Center scientific review committee of 14 members, 6 of whom are from UAB and 1 also from Seattle, Washington, Fred Hutch. Clinical trials, I'll talk to you about it. Publications first year, a dearth of it, but I'll tell you about it. And Upenda will help me explain what we've done together. And in terms of grants, It's ambitious to think we'd get a grant so quickly, but I'll tell you about some of the early stages where we are. So when we established the Clinical Research Unit, the CRU, it was COVID first wave. Tocilizumab was in North America, was being given at UAB everywhere in North America, but there was no real data. The first randomized phase 3 trial for tocilizumab in patients who were on the ventilator was negative. It was in fact not beneficial, not detrimental, but certainly not beneficial to give interleukin 6 receptor antagonist antibody. This was a study to give in patients who are not on a ventilator. We were somehow selected by Roche because we just established ourselves. I knew Roche well from America, and they said, okay, we'll give you a chance. We were the highest accrual of COVID-19 patients on the tocilizumab randomized controlled trial, placebo-controlled trial. And as a result of the being the highest accrual in Africa, we received obviously a publication authorship on the NEJM. And you see Rina Shah, who is our ID faculty, became a first author. First paper NEJM for her, first paper AKU in Kenya, and clearly a testament to say that we could do research, although this was COVID research, inpatient research using tocilizumab, an antibody that I knew something about because we use it for CAR T cell therapy when you have a cytokine storm. So it was really encouraging in terms of a trust that Roche had with us. As a result of that, we said we could do clinical trials. And you remember Emory University about 2 years ago developed a protocol using low-dose radiotherapy for COVID-19 pneumonia. Because radiotherapy, 100 centigrade, can really try to eradicate the microenvironment, macrophages, accessory cells, all of which, including some T cells, produce IL-6 that results in the cytokine storm. So based upon the Emory work, we talked to the physicians at Emory. We have a good radiation therapy unit here. I became the PI of our first IIT using low-dose RT in the treatment of COVID-19 pneumonia. We accrued 10 patients. This was the first IIT done in East Africa, period. Accrued 10 patients. First 5 sailed through this, no problem. The next 4 nearly did bad and went on to die. And 1 is still in the hospital about to leave. So we were not looking at efficacy. We were looking at feasibility and toxicity. We're able to show they were safe. And there are 11 studies in North America and Europe going on for low-dose RT. And we just talked with the dean last week to say whether we should do this on a compassionate basis because we have a hospital full, a country full of COVID, no ventilators, no beds. Low-dose RT could possibly be a helpful aid. We do not know whether it's effective. At least we know that it's non-toxic, and we do not have tocilizumab because our supplies are running short. So this was the first foray in clinical trials that we did here for the first time ever because trials were not coming to us. At least Genentech looked at us and gave us a first chance with tocilizumab. So what's happened since? In the meantime, Roche has come back to us and they are giving us a trial of the antibody ocrelizumab, which is an anti-CD20, a cousin of Rituxan. It is very effective in multiple sclerosis, relapsing multiple sclerosis. This study was done at UAB by the neurology department. So they have an open label study because African Americans and Mexicans showed a predilection to better response than Caucasians using anti-CD20, the ocrelizumab. So they wanted to accrue more Africans. So we are now going to be the recipient of this trial. Even though the CRU is dedicated to oncology, we will do this study because we think it was important because I was involved in the development of Rituxan anti-CD20 a long time ago with Ed Labulio. The trouble is the neurologists here have the biggest cohort of MS patients in Africa, nearly 50, but they've never done clinical trials. And those of you who've done trials before, it is really a labor of love, and regulatory authorities are very sharp to jump on you and penalize you if you don't do things well. So I will be the PI of the study just because I know anti-CD20, the neurologists will be co-eyes, but they'll be the ones helping me treat those patients. And lo and behold, we also now have an adjuvant therapy trial, the GDC 9545, which is a SERD, a serum serum androgen receptor, I think degrading agent, very much like fulvestrant, but it's oral. It's a degrading agent that also blocks the ER receptor. There'll be a phase 3 randomized trial starting here in July. It will be for patients who are ER/PR positive in the adjuvant setting. We've never had a trial like this come to Africa, at least north of South Africa, and this will be the first trial. And it's a phase 3 trial. But more than that, given the prowess we showed with tocilizumab, Genentech has come back to us to give us a 3-arm phase 2 trial of 2 bispecific antibodies, which is RO7121661, anti-PD-1 plus anti-TIM3 bispecific antibody, as well as anti-PD-1 plus LAG3 antibody, and the other anti-PD-L1, which is their own PD-L1. I would be drooling if I was at UAB if a study like this came to me. So you can imagine how gratifying it is that we have this study coming our way to start in July. So I think starting from tocilizumab in 2020, we in 2021 will have our first 3 clinical trials, which we will do here in the CRU. And I think that's a little bit of a progress for our own trajectory. So this is the paper that was published in the NEJM. Just recently, we've been working with Upender for a long time. I took triple negative breast cancer tissue from here, brought them to Alabama, and he had tissue from African American from Alabama and Caucasians. And we looked at the transcriptome and the mRNA sequence of these patients and see if there was a difference. And there is a difference. We'll talk about it in a minute. And then most recently, we published a paper, just got accepted in Clinical Cancer Research, the dual inhibitor of MDM2, MDMX, something I started at UAB. This was the first phase 1 study I did at UAB when I came in 2015, and it was just finished. The paper was just completed now. We have a paper that at least I can take credit for, but for my alma mater at UAB. And maybe I should ask Upender to unmute himself and talk about this paper and these 2 slides. Maybe Upender can do this better than I can do. Upender, you want to do that?
Okay, this is on the spot, but anyway, I'll try my best. So, the main objective of this study is to, as we know, any breast cancer or any cancers, the clinical outcomes and the presentations are distinctly different in different racial ethnic groups. So when Mansoor, spoke to me, hey, I have a nice frozen samples TNBCs collected from Kenya. And at that time, we were already conducting these RNA sequencing studies on African Americans and Caucasians here. And his sample size was small. So then what we did, I think it's about 15 samples, age matched, stage matched, African Americans and Caucasians. And we took around 20 African Americans and Caucasians and 15 from Kenyan pop, TNB, all of them are TNBCs. And we double confirmed here by in situ hybridization, because how they classify there, how they categorize, diagnosis, slightly different. So we did again, then we did the gene expression studies. Of course, when you do this sequencing analysis, a lot of data, and when we analyzed with the help of Suri and Darshan from our pathology, and we identified about 175 distinctly overexpressed downregulated genes in Kenyan population. Then if you see this heat map, there are some, so most of them are similar in their expression profiles. There are some differences, and we further sieved down and focused on 45 genes. Out of that, about 25 genes are upregulated in Kenyan population and 20 downregulated in that population. Particularly in Kenya, I learned from his he educated us that Kenya is not a homogeneous population. Again, there are a lot of tribes. And I think if I remember well, this is a Bantu ancestry population, right, Mansoor? You are muted.
No, go ahead. I was just talking to Innocent.
So there's Bantu, the specific ancestry, and we found very interesting, after sieving through all this data, there are about 11 unique genes which are overexpressed in TNBCs, triple negative breast cancers of African ancestry. And 3 of them are, apoptotic pathway involved in apoptotic pathway, 6 or 7 in proliferative pathway, and the others are in different pathways. So now actually it just got accepted, and today we got the galley. So now we need to validate these studies. This is all bioinformatically identified genes, but we are in the process. Next step is we will validate them by immunohistochemistry and see are they truly overexpressed only in triple negative breast cancers of Kenyan ancestry versus our African Americans and Caucasians. Even though when we started this project with that objective, but actually, once we saw the data, we can do a lot of other genetic drift and gene pool evolution. I know most of the African Americans are coming from East Africa, if I am right, those who migrated to United States, but these are from West Africa. And how within that, how many genes are distinctly different. So we need to work with genetic statistical geneticists to run through this data and identify some of those ancestry related questions also. So this is post idea, Mansoor. But for you, if you want to bring this into clinic at your place, I think this immunohistochemical validation is the key for those 11 genes. I'm hoping at least 2 or 3 may pan out, then that will help you tremendously, at your place. I'll stop there.
Absolutely. I only showed the downregulated genes. There's another slide for upregulated genes and the specific pathways that these genes are taking. And clearly there were differences. And I think the IHCs that you mentioned, we just had to identify some of those proteins and maybe using that specifically as an IHC marker for TNBC in Africa. So we need to continue this. It just shows that so much could be done together. George Netto linked me up with Ryan Miller. We talked to the neurosurgeon, neurologist here, because we see quite a few glioblastomas, high grade, and we don't see as many African Americans in Alabama. And there's another place where we could work together. So I am grateful to you, to Suri, to Darshan, to Kim, all of whom really work together. We have the resources. I think we have the knowledge, but the technology that you bring will be helping us to learn more and do it ourselves here in the future. But this is the beginning of this kind of collaboration. And I think we got the paper accepted and Galley's right on the right day today. So this is good. So thank you. Thank you, our team, Suri, Darshan, and your end. So, grants are important when you have a cancer center. It's my first year, and I don't know whether I could be successfully writing grants. You guys are very prolific about that. What we got is a PI, the 2020 ESCO Innovations Award, to do the clinical investigator training program, to train colleagues here to become clinical investigators. As you remember, I developed CITP at UAB. We trained nearly 60 fellows and junior faculty to become clinical investigators. I took that and brought it here to see whether we can do the same here, so that we can have more people do clinical investigation and become sub-Is who can help really grow the pool of people who do clinical investigation. Grants are important, more important as validation, including publications. We just submitted an NIHR grant, which is dedicated to research and capacity building and strengthening in the area of NCD. And we selected colon cancer, cancer, mental health, and diabetes as the 3 NCDs we'd like to focus on. We worked with the University of Edinburgh on that. And I just finished a call before I started with you, with the University of Michigan, with whom we have an MOU. And we're going to look at a cancer prevention, detection, and diagnosis technology development to see whether we can get early detection of cancers using algorithms and data science methodology and innovative technology. So those are the beginnings. And I think that there may be many people at the UAB or writing grants that require an LMIC partner. And that's what I would like to do. I work with Jenna Turan at the Sparkman Institute. We're going to do a stigma study. They have a NCI supplemental grant to do stigma study in breast cancer, which we're going to do right here with the protocol. But unfortunately, because this is the last year of the UAB's current cancer center program, we were not eligible. So we'll have to wait until we get funded again. But a number of places where we collaborate together. And my role here is to establish at least a beachhead that you can trust. And since you know me, hopefully we can work together on future projects. So before I end the last 5 minutes, see what COVID has done to us. These are the 3 waves of COVID we've had. I came to Nairobi sometime January 2020. By March, 2 months later, we had a lockdown. And by July, we had this big wave, significant number of deaths. Now, if you look at our numbers, 124,000 cases in terms of positive cases, 2,000 deaths. You guys have, I think, was it millions, 500,000 deaths and 334 million cases. I mean, we can't even comprehend your morbidity and mortality. We don't understand why we're this low. Partly it's because we don't screen everybody. We don't have screenings for everybody. So clearly our numbers are deflated. But somehow the Kenyan population is young, median age 20, as opposed to 50 plus in North America. And somehow there is something about either the genome or exposure to infectious diseases or whatever else we may be doing that we are somehow protected in many ways. So while we are all masked most of the time, the population is really not paying attention. However, we are much better than our neighboring countries, Tanzania, where I was born, where Tanzania is total denier of COVID. And despite the fact that the president, vice president, a number of ministers have died of COVID, that country says COVID does not exist and they will not be vaccinated. So you see different problems, but this is the 3 waves we've been experiencing. And now, as you can see here in March, we probably have our biggest wave, bigger than I think we had in November. And this may be a variant from South Africa, we are not quite sure. We have all samples stored. We also have the same thing that you guys have at UAB, whereby every excess serum sample that will be thrown away is stored for future research. So we have a number of biobanks platforms here where we can do research in retrospect. If you look at our testing here at the AKU, if you come to the ER, you get tested. If you get admitted to the hospital via some private doctors, you get tested, and you get tested by a community tent where anybody from the community can come and get tested. You can see our rate in the first wave was about 20% positive, 20% positive. Now it's about 26% positive. 1 in 4 people coming for testing are positive for COVID. So you can understand why we are going through this 3rd wave, partly because of non-masking, but there is something else going on that is causing this dilemma. These are the admissions in the hospital. And in essence, that was my last slide. I learned a lot from UAB. I'm totally indebted to all of you, Shuko, and people who taught me what I can do, but I had to take it from there to bring in the LMIC context. And in many ways, the lessons I learned in Alabama taught me a lot. But I have to be patient, I can tell you. It doesn't happen overnight. I don't have a team like you over there where you can just cross the alley and there's a vendor, Suri or somebody else, or Shuko to say, can you do this for me? But I think we can collaborate, and that was my last slide. So I appreciate you giving me the opportunity to do this. Thank you.
Thank you so much. That was excellent. And despite all, it was such a harrowing story, and the fact that with even all these hurdles, we can still have this meeting and you can still share the story with us. It's very excellent. There were a couple questions in the chat. Dr. Alexander, do you want to expand upon your question?
I'm muted, Adam. Okay, now. No, just to get an idea of his support there from pathology and in the continent of Africa. I was in Bamako, Mali for a week, and I understand a lot of limitations. So just whatever Dr. Mansoor wants to talk about.
Thank you. Appreciate it. You know the dilemmas. Bamako, West Africa, different pathology, different genomics, but the same issues exist. So we have a very good pathology department, but I think if we can do more with UAB, and I think as travel gets better, I think this will work out, and maybe one of these days I could come or somebody could come from there. But I really appreciate the support that you guys have given me. And Bruce, thank you for your comments.
Yeah.
Dr. Harada, do you want to expand upon your questions as well?
Sure. Yeah, excellent talk. And I'm so, this is great that African cancer patient getting similar clinical trial options that we have here. I'm just wondering if maybe the patient comes a later stage if the screening or early diagnostic mechanism is not working very well. I'm just wondering how that is in Africa, your area.
Good point, Shuko. It is absolutely true. We don't see significant early disease because of stigma, because of expense. The other day, I saw a young patient with Burkitt's lymphoma. They live about 30 miles away from here. It took a month for the family to get funds, to get a bus fare, a train fare for the entire family to come here. By the time they came here, this tumor was just like a little mole had taken over his whole face. Now, Burkitt's lymphoma you can treat very quickly, but the same thing happens with breast cancer, colon cancer, prostate cancer. You know, we just had colon cancer month last month, March, and we worked with University of Michigan to promote awareness. 20% of colon cancer in Kenya occurring in men under the age of 40. And 60% of men or women with colon cancer present with stage 3, 4 disease. Well, awareness is not there, expense, and it is totally mind-boggling for you. When I'm in clinic and I order a CBC, you know, you say CBC, you put it in your EMR, done. The patient is going to go and pay for the CBC in the business office. Once you pay, then go to the lab to get the blood drawn, et cetera, et cetera. So you can imagine there are many hurdles here. And 20% of patients have top dog, like Blue Cross Blue Shield insurance. They get everything. 30% have federal insurance where they get subsidized, but they have to pay for most of the care. And the other 45% or 40% have no insurance out of pocket. And most of the people here subsist just from hand to mouth. So it's a difficult world. And when we bring clinical trials, the good thing about clinical trials is, it doesn't matter how old, rich, or poor you are, clinical trials are paid for by the sponsor. And that's one advantage of doing trials here.
Thank you.
Adam, can I make a comment? Yeah, so a couple of comments. First, congratulations, Mansoor. It's a humongous task and a daring step, you know, going back to the, you know, challenging environments and trying to make some impact. I really kudos and outstanding. And the next comment is on high proportion of triple negative breast cancers in Kenya. We know African descent individuals have high proportions of triple negative breast cancers. You know, I gave a talk 3 years ago in a large cancer center in foothills of Himalayas in India. At Dehradun is a nice hilly place. There, they reported about 35 to 40% of triple negative breast cancers. I know, you know, human evolution wise, Indians are more closer to Africans, or Africans, you know, same gene pool and all that stuff. So I thought that may be similar. However, at that time, there was a paper published by David Rim of Yale on the delay to fixation and the length of fixation of the these breast cancer tissues, how long you are fixing these in formalin, and how quickly you are putting this frozen sample in the fixative has a tremendous impact on if you are measuring this triple negative status based on immunohistochemistry, those are the issues. And this suggestion, I made a comment because I'm not a pathologist, but I know a little bit about by rubbing shoulders with my pathology colleagues here. I learned and I shared there, and they did and implemented that. You won't believe, from 40%, it came down to 32%. So systematically for the last 2 years, they are capturing this data, and you need to fix this sample within 1 hour after taking out of the body. Then the length of fixation should be less than 4 hours. So the very defined protocols, and that made an impact. So that's what, you know, I know you showed 28% there's a max in 4 samples, but I think that's one issue. I suggest you to talk to your pathology colleagues there and address that issue.
Upender, absolutely correct. In fact, they published this. You know, when I came here 4 years ago, we did a course on biopsying, cold time, etc. Most of the patients in Kenya were not using 10% buffered formalin. They were using formaldehyde because, you know, it does not go stale. Well, formaldehyde will cook anything. Everything becomes triple negative. So we taught all of them. And now our biggest trouble is our tissue clearly is done exactly that. Full time, limited, formalin fixation, limited, and then you do very quickly your IHCs, etc. But the pathology we get from outside, you report ERP positive. Oh, you can't hear me? You can report ERP positive from outside samples, but you cannot quite be sure how they were processed. So very important, we have to do another training for people outside. Yes.
Mansoor, this is Vishnu. Actually, that's a great talk. Congratulations and the best wishes. I mean, it's a wonderful talk.
Thank you. In fact, Vishnu, I thought about you. You were one of those who knew me as a fellow, and you taught me how to read bone marrows. In the meantime, I don't read bone marrows anymore, but we would like some help. We see quite a bit of acute leukemia and multiple myeloma, significant. If we could get help with, IHCs are not used in hematology, it's more for cytometry. We have a flow cytometrist here, but getting some help to see how our leukemias, MDSs are different than yours will be very helpful. I will link up with you again. Thank you.
Yeah, sure. I'll be glad to work on. All the best.
Thanks.
Oh, great. Thank you so much. So is the cat behind you, is that the same one from the hotel?
No, this is the small leopard. This small leopard. This is our animal logo, just like you have the Alabama elephant or whatever it is in Alabama. This is the AKU mascot.
Nice.
It wasn't the same for sure. No.
Well, thank you so much. That was fantastic. And thank you for being flexible with the time. I definitely appreciate your ability to get in there. So congratulations on all you've done so far, and best of luck in continuing with that plan. Thank you.
Thanks, and thank you to George Neto, your chief, because it really was inspiring to me to help me get here, and I would love to collaborate more with you guys. Right?
He had definitely asked to introduce you today, but he had a last-minute conflict, so I sent his apologies for that.
Thank you. Take care.
Thank you.
Thank you.